Hello, I'm Erin Cox, physiotherapist. We're going to continue on talking about the wrist and hand anatomy. I'm going to share the screen with you because now we're going to talk about neurology and vascularization. So first of all, in neurology, we have something called Hilton's law. And what that means is that specific articular innervation to the fingers and hand is supplied by the same nerve that supplies the skin and the muscles overlying that joint and acting on the joint. So any nerve serving a muscle that produces movement at a joint also innervates the joint itself and the skin over the joint junctions with skeletal muscle cells. So the median nerve, its cervical segmental supply is C5 to T1, and the motor supply, it supplies the thumb and wrist flexors, except for the flexor carpi ulnaris and the ulnar half of the flexor digitorum profundus. So basically, the median nerve supplies the radial side of the hand, and then this would also include the radial two lumbricals and the thenar muscles. So this would be where the skin innervation for the median nerve would be. Now we'll also look at the ulnar and then the radial. So the radial, of course, is going to be more on the posterior. The median comes over the posterior side, over the DIPs. And don't forget, we have half of that, usually about half of that fourth finger, the ulnar side by the ulnar nerve, and the median on the median side. So the median nerve, the sensory supply, there's a central palmar skin and thenar eminence. Palmar aspects of the first to third and a half, including the dorsal aspect of the distal phalanges. The articular supply for the median nerve would be the distal radio-ulnar joints, the radiocarpal and carpal joints, and the most discrete region, or the signature zone, termed by Butler, would be the tip of the second digit. So if we wanted to more find out if the median nerve is at fault or not. The ulnar, the cervical segmental supply is C8 T1 with a little bit of C7. And this would be the small hand muscles, of course, except for the radial two lumbricals, because the radial side is more the median nerve, the ulnar is the ulnar side, so the hypothenar muscles, and then the flexor carpi ulnaris. The ulnar nerve, the ulnar aspect of the palmar skin, and the ulnar aspect of the fourth digit, including more the half, again, split with the median nerve, and the dorsal and palmar aspects this time. And the articular supply, the precise details are not really known, but it's thought to supply the wrist, some of the intercarpals, the CMC, and the intermetacarpal joints. Its most discrete region is the tip of the fifth. The radial nerve, the cervical segmental supply, is C5 to C8 with a little bit of T1. The motor supply supplies the long and the short wrist, finger, and thumb extensors, because of course on the extensor side, and the supinators. And again, as we said, it does not go over the tips of the finger. It stays more here in the web space is often a notable spot for the radial nerve. So the dorsum of the hand and digits, 1 to 3.5 to DIP joints. And again, is it here or here? Some of that varies in the literature. But the lateral aspect of the thenar eminence, the articular supply are the carpal ligaments, carpal, distal, radio-ulnar, intercarpal, intermetacarpal, MCP, and PIP joints. And again, I said the most discrete region would be the dorsal web space. Just to compare the cervical segmental, we also have C6, which is more on the radial side. The article that I already gave you about Rainville, if you wanted, it would be more the distal lateral radius. So that's how you could distinguish it between the median nerve. The C7 is the mid-palm, and mostly the third digit, which is, again, different than the peripheral nerves. And then the hypothenar would be the C8. So there is more of your picture. We don't have that half of the finger when we're talking about the cervical innervation to sensory innervation. Your specific motor supply, you can read also in the notes. But we also have specific, hold on, there we go, comparing the two. So the distribution, again, this is the cervical segments and this is the periphery here. Of course, the innervation is important for grip. We have the power grip, which is a little bit more the ulnar nerve involved, the precision grip or the pinch grip, which is more the median nerve, and then the wide grip and the proximal stabilization. So normally we want about 30 degrees extension in the wrist to have optimal wrist strength. So obviously the radial nerve has to innervate the extensors, because if you lose that, we can't grasp as well as we can in a little bit of extension. Vascular supply. So the ventral or palmar branches from the radial and ulnar and interosseous arteries supply the wrist and hand. So there we have those vascular arches into the hand. There are many astomoses between these vessels, ensuring good vascular flow to the wrist and the hand. And there are 3 dorsal and 3 palmar arches traversing the carpus. And these are the arches, as we were talking about. Here's one of them here. And you can see this would be the ulnar and the radial arteries. The clinical significance for the vascular areas, the scaphoid and the lunate have vulnerable vascular supplies. So the scaphoid has nutrient vessels entering at the waist and the distal pole. So instead of it going from proximal to distal, it loops distally and then loops back and comes down back into the scaphoid. So nutrition of the proximal pole is dependent on the vascular flow from these distal portions. Following a scaphoid fracture, the vascular supply can be interrupted, resulting in osteonecrosis of the proximal pole. So we can see here how we've got, this is your scaphoid. We have the dorsal carpal branch of the radial artery, and a part of it branches off and enters into the distal pole of the scaphoid, and now these little branches work backwards. So you don't have hardly any supply into the proximal pole. And you can see the fracture here. Kienz-Bock's disease, and so this is more of the lunate this time, and the lunate vascular supply is a bit like a watershed. So the vascular supply is got from dorsal and palmar nutrient vessels through anastomosis. So it's not necessarily direct vascularization, which can cause more of an osteonecrosis if there's a problem. And there you go. Have a little break. I know I will. Thank you.